All right, well, welcome everybody to Maternal Infant Health Canada's educational seminar series. Today's webinar is on SmartMOM, texting or teaching by texting. And I'll just put our disclaimer up because as with all of our public webinars, I must add the following disclaimer. This course and how notes contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. All right, now we can get back to the real good stuff. I will start off with some introductions for those of you who have not seen our webinars before. These webinars are hosted by Maternal Infant Health Canada, MIHCAN for short. We are comprised of doctors, researchers, traditional medicine practitioners from Canada, India, and around the world. Together we aim to work closely with local healthcare providers, traditional medicine providers, government, and community members to improve maternal and infant well-being and reduce preventable maternal and infant mortality in India and globally. MIHCAN recognizes that the only way to make a true lasting impact is to look at all determinants of maternal and infant health. Today's webinar, which is part of our health education and clinical skills training, is on SmartMOM, Teaching by Texting, which is a prenatal education program delivered by text messaging. Our speakers today are Dr. Patty Jansen, a professor and co-lead of the Maternal Child Health theme at UBC School of Population and Public Health and the creator of SmartMOM. We're also joined by a leading maternal and infant health expert, Dr. Kranti Suresh Vora. Dr. Vora received her MD from Gujarat University, her Master's of Public Health from Johns Hopkins School of Public Health, and a PhD from the University of Maryland. Today she'll be offering commentary and discussion around the application of this technology in India and the Global South. I am Dr. Emily Solomons, a doctor of traditional Chinese medicine in Vancouver, Canada, and the co-president of the Obstetrical Acupuncture Association, and I will be moderating for today. The webinar will run roughly an hour. We're going to try and stick to that. But for those of you watching live, I encourage you to write your questions in the comment box. I think for most people it's going to be on the side, but it might also be below. We will capture the questions and ask them before the end of the hour. I will keep my fingers and toes crossed that the internet is going to remain smooth throughout the webinar. As I know, sometimes it can get a little bit touch and go when we have multiple countries tuning in. So hopefully everything's going to work nice and smoothly today. So to be patient if there's any glitches. Why don't we start and begin with Dr. Jansen. Can you share with us a little bit about this incredible project you've created?
Sure, I'll start with my slides, and thank you everyone for joining us today. So our program stemmed from the fact that we're aware that in Canada fewer and fewer parents attend prenatal education classes. And in some places in our northern rural areas, there aren't any classes or people can't get to them because they're so far away, and we also have to deal with major geographical barriers, poor weather, bad road conditions, etc. And so we need to look at other ways of delivering education. And the Northern Health Authority asked us if we could think of a way to deliver prenatal education to their women. And so we looked at text messaging because we know that over 90% of women in the North have a cell phone. And we know that randomized controlled trials have shown that text messages has been effective in provoking behavior change. And so we designed SmartMOM so that we could increase access to evidence-based information to support healthy pregnancies. And it's important when we say evidence-based because, as you know, there are many, many apps out there. Some women are on 4 or 5 pregnancy apps. The majority of these are either run by lay parent groups or by organizations with commercial interests. Almost none of them have scientific boards, and we wanted to make sure that women were getting accurate evidence-based information. So I'm going to talk a little bit at the end about Smart Parent as well. And Smart Parent is a program for new parents to support the health of their baby from birth to 1 year of age. So just looking at our Canadian situation, we know that women aren't getting the information they need because of a number of studies that have been done so far that show people, for example, don't know that the flu vaccine in pregnancy is safe. People are not aware of what is an appropriate weight gain and how important this is. And again, that an overview of 370 apps from Google Play reported that only 3 actually had a scientific board or advisory committee. So women are still not getting the information they need to make informed choices. So SmartMOM is Canada's first prenatal education program via text messaging. And our messages provide information. Each message has a link in it which takes them to an evidence-based source of information. We suggest topics of conversation with their providers. And the links take women to local resources or to even more broadly national resources and even international sources of information. So this is just a picture of where you might end up if you click a link. It could be from our BC Ministry of Health, from the Canadian Public Health Agency, or elsewhere. So why did we develop it? Well, as we said, the request came to us from the north, but our messages are able to link women to websites, phone numbers. We give them videos, we tell them about screening, and we help them prepare for labor and delivery. And our program has been endorsed by the Society of Obstetricians and Gynecologists of Canada. This is only 2 that I know of in the world that have been endorsed by national regulatory agencies, and the other one is in the UK with the Royal College of Physicians and Surgeons there. So how does this change prenatal education? We have a partnership with the Canadian Wireless Telecommunications Agency, and they regulate the practice of our carriers such as Rogers, TELUS, Bell, all of the carriers that supply cell phone coverage to women. And they lobbied on our behalf to all the major commercial carriers and successfully persuaded them to offer this service to women for free. And so none of the women pay for the service, and we don't have to pay to send them messages. Also, it makes prenatal education available to everyone. All you need to do is have a cell phone. And in some areas in our province, we still don't have cellular coverage, so people can get the program through the internet as well as by cellular coverage. In order for a program to engage people, it should be interactive. And so our messages take people to quizzes, they learn how to count calories, they can practice position changes with pictures and with videos, etc. And it's also important for engagement that a program can be tailored to individual needs. So we have a number of supplemental messages that women can opt into. So when we started this program, we did focus groups in the north with women to ask them what they wanted, and they said what we don't want is to get messages we don't need. So if we don't smoke, don't send us smoking messages. So what we do now is we ask people, would you like to have help with tobacco reduction? And then if they do, then they can opt into a supplemental suite of messages. And so in the north, women have their first prenatal visit with a nurse, and that nurse helps them to sign up for the program right there at that very first visit. There are posters out in the community to remind people. We give people fridge magnets to remind them about SmartMOM. This is Fraser Health Authority, which is the largest health authority in the province. And in this health authority, women sign up for a prenatal registry, and they have over 99% compliant with that. And so when they do sign up, they also sign up for SmartMOM. And then this is the Interior Health, which is another big health authority. We just have 5 health authorities in our province. And they also sign up for the program when they sign up to their regional health authority for their prenatal registry. So this is what it looks like on the phone. It's very easy. You just text SmartMOM to 12323, and then you'll get a welcome message, and you reply yes, and then you review the terms of consent, and you then accept them, and then you enter your stage of pregnancy so that the messages can be synced to where you are in your pregnancy. And then here's the website where you can also sign in, and you can sign in using your email there if you don't have access to a cell phone. And so you make up your own profile, your time zone, your due date, and you can choose here which supplemental messages you want, and you can let us know what days of the week and what time of day you want to get your messages so that they're going to arrive when you actually have time to look at them. So these are the supplemental message streams, and you can see we have smoking, alcohol and substance use, depression, VBAC, vaginal birth after previous cesarean, weight management. For women who have lost a pregnancy during the time of they're using SmartMOM, we didn't want to just leave them in that situation, so we do refer them to our supplemental stream and the resources there. And we have something for new immigrants, for women having their first baby over age 35, and exposure to violence. And sadly, exposure to violence is the second most frequently used supplemental stream. And I think that's important because people can do this anonymously. And so they can get help here without having to talk to anyone if they don't want to talk to anyone, keeping in mind that some of our rural and remote areas are very tiny towns where there's very little privacy. So this becomes very important to women to be able to have privacy as they try to reach out and get some help. So in terms of our evaluation, we have a number of surveys that we ask women. Now, people don't have to fill out the surveys to be on the program, and because of our partnership with health authorities, it's viewed as a program as well as a research project. So they can have the program whether they do the surveys or not, but we do encourage them, and then we have a draw for a $100 gift certificate for every 20 people that enroll. So we start out just with some demographic information, and then we do a little pop quiz, and we compare the findings of our pop quiz at the beginning and at the end of the pregnancy. We also have a survey about fear of childbirth, and we've also included the Edinburgh postpartum depression scale so that we look at depression and anxiety at the beginning and at the end of the pregnancy. We also have a sign-in for care providers, so it's important to acknowledge that the program is for healthy women. We are not trying to offer this to people with complications, and caregivers, if they're not sure if someone should be using this program, they can sign in as a caregiver, they see all the messages, and then they can advise women that the program is good for them to use, or that they may have to do something different in 1 or 2 areas depending on their particular situation. And so this is just an example of the whole list of messages. And if women signed up at 20 weeks of pregnancy, they can also go back and review all the messages that would have been sent earlier if they had joined early, and they can go to the links. And so one of the functions of the program is to connect women to community resources. So when people sign up, they have to indicate which health authority they're from, and then those health authorities landing page so that they can be on a page for their own health authority that tells them where all the pregnancy resources are in that health authority. So this is an example of the Northern Health Authority. They can click on a dot and then another screen that will come up that will say, here's all of the pregnancy services in this town. So the health authorities take some ownership over this, and we encourage them to do that. And so in Fraser Health, they have some resources that they want women to know about at a particular time in pregnancy. So Fraser has their own suite of supplemental messages going out, and this is just an example of where they're sending people in their particular area. So one could ask the question, why do we think that text messaging changes behavior? Because if you think about it, it's a bit of a stretch to think, well, women watch TV, they read books, they're on apps. Why do we think text messages it's going to do anything extra? And there have been a number of articles published now, not in pregnancy, but in other areas, which are showing that it has been an effective tool for behavior change. But in pregnancy, in some low-resource countries, it has been shown to improve attendance at prenatal care and lower the risk of low birth weight babies from South Africa, from Zanzibar, actually reductions in perinatal mortality. And these texting programs are sent to women to ask them how they're doing, do they need HIV medication, etc. And women can actually use the phones to call back if they need help. Now, our program is one-way messaging, so we are not getting contacted by women. We do have a 1-800 number in case they're having trouble enrolling, but these are really one-way messages. We do have a video, and I'm not going to go in this now, but I'm sure that Dr. Solomons can give you access to these slides, and then if you look at this in slide view, you can click on the slideshow and see about an 8-minute video. So what do women say? They like SmartMOM because they feel that the information they get is comprehensive, and they're not worried that they're going to miss anything out. And the information lands right in their lap, and they don't have to look for it. And this is the deterrent to going to big websites. And, you know, there are organizations out there that have fabulous websites, for example, the American College of Nurse Midwives, but even I am intimidated going to that website. And so they like that a lot, and they also like that it's a reputable source and that they can trust it. And they also find that it helps them prepare for their visit to their caregiver, because they make a list of questions as they get their different messages. And you know, we've been amazed to find out what women's needs are. So I never would have thought in British Columbia that Rh negative women would not get RhoGAM to protect their baby from an immune reaction in a subsequent pregnancy if they're Rh negative, but in fact, some women are not getting it. And so that's a message that we've had to add to the program, and it's constantly evolving as we continue to get feedback both from our users and from our content experts in the health authorities. So what do caregivers say? They feel very relieved that they can trust this source. We have a large advisory committee that I'll tell you more about later. And so our messages have undergone a huge amount of interdisciplinary scrutiny before we have offered them. And also nurses say that women feel empowered by this because they can take the messages and follow the links to get information that's of particular interest and relevance to them. So our goals have been to develop and implement the SmartMOM program in BC Health Authorities. So we're in 4 out of 5 now, and I'm sure the 5th one will join. And to compare health knowledge at the beginning and end of the program, see if it increases access to local resources, and ultimately look at outcomes and how they change. So once again, why would we expect that text messages would change behavior? And so the idea under this, there's a lot of theoretical information behind this. So under the social cognitive theory, we are modeling healthy behaviors through these messages, and that this promotes self-efficacy and expectations for good outcomes. And so we want to engage women with the program, and that's why we try and make things interactive. Under the health belief model, giving messages as a cue to action means that they get it just in time, because it's geared to their gestational age. When they get the message, then they act. And once again, that's something that motivates behavior change. Theory of planned behavior, same thing. When you receive information at the point where you're making a decision, then you're stimulated to think about it, to have feelings about it, and then intend to change behavior. And then something called the situational theory of publics is a public relations theory. And what it says is that however personally irrelevant, however relevant a problem can be for an individual, increases their likelihood of comprehending the messages and acting on them. So that's why we have the individual streams. And so it helps people to recognize problems, believe that something needs to be done, and then it enables them to actually do something so that they feel they have control over it. And that we're trying to get around the constraints of low health literacy and poor knowledge and bridge those gaps so that people can actually take a step to call someone to look at something and to reach out. So we have undertaken both our ethics approval and a privacy impact assessment, and we do our tests at a moment and at the end of the pregnancy, and we are hoping to not just do our surveys online, but we ask women to give us their personal health number, which is a unique identifier in BC. And with that health number, we can give that to health authorities, and they will send us hard outcomes such as preterm birth rate, stillbirth rate, weight gain, etc. Now, we don't ever see those personal health numbers. They go to Memotext in Toronto, who's our industry partner, and Memotext has developed the software for SmartMOM. So the personal health numbers are encrypted, and they go to Memotext, and then Memotext sends them to the health authority, and then the health authority sends us the data, but with the PHNs removed, so no identifiers on it. So we just know that someone either was in the program or they weren't. So we have a control group of women that weren't in the program. So we haven't done this part of it yet because it's going to cost money to download that data, and we're needing to get enough people through their whole pregnancy such that we can look at that outcome data for a large number of people at once. So we have about 5,000 women in SmartMOM. The vast majority have a smartphone. Their gestational age and enrollment is all over the place, but it tends to be about 18 weeks, so that's an area that we need to look at so that we can get people enrolled earlier than that. We are reaching young women, so about 80% of the women who are using SmartMOM are under the age of 24, which is really a target group that we wanted to reach. And interestingly, 9.4% of our clients are Indigenous, so the number of Indigenous women in the province is a proportion of about 5%, so we are enrolling Indigenous women at a higher rate than our provincial proportion, which means that they are engaged with the program and finding that it is accessible to them. About 70% of our clients are first-time moms. They're nulliparous. And I thought they all would be, but there are repeat moms that are interested. 12% with single parents, so that's another target group that we're reaching. And I can't quite see the numbers on my slide, but I think it was about 25% or so that have grade 12 education or less. So we are reaching women who are young, Indigenous, immigrant, single parents, and with less education. Okay. So when we asked women, well, where do you find out about pregnancy now? A lot found out from their doctor and from their friends and from their family, some from classes and from websites. And not as many from telephone apps as we thought. When we asked them why they chose SmartMOM, given that they have all these other sources of information, what they found very important was that it was the convenience of it, that it was so easy, they didn't have to work for information, it was free of charge, and they liked the reminders about their appointments, that it was evidence-based, and that they had various sort of tips to help them get through their pregnancies. So we have shown that we are statistically significantly increasing the scores on the knowledge test, and we are improving scores on both the depression scale and the fear of childbirth scale. Looking at the links that people are going to, they're particularly interested in nausea and vomiting, genetic testing, screening tests, getting labor support help, prenatal registries, pregnancy calendars, food tracking, and symptoms of preterm labor. And then we talked a bit about the supplemental streams already. So our SmartMOM team consists of a number of provincial agencies. We work closely with our First Nations Health Authority, and we've taken their advice on the questions we ask about Indigenous status. Our industry partner is Memotext. We also work with a company called Impact Mobile. So when Memotext sends out a message, it actually goes to Impact Mobile, and they funnel those messages to individual people through their different accounts. We do have a patient advocate on our advisory committee as well. And we do seek and receive feedback from people all the time about the program. So SmartMOM has been up and running for about 1.5 years in the north and about 6 or 7 months in the other health authorities. We have funding for Smart Parent, and we have developed a program, but we're just making our website now, so we should be launching it in about 6 months. And we found that new parents are also having difficulty accessing good information and care for their children. And the same problems with the online parenting information is not necessarily accurate. So Smart Parent will work the same way as SmartMOM, except it's for a whole first year of life. And we will also start with a knowledge quiz, and we have as well scales on parenting competence and confidence. And we will also be looking at hard outcomes from this as well. And we have something called POP data, which is our provincial linked data source, and we'll be able to use this to look at things like whether babies are being taken to get their immunizations, accidents, injuries, use of emergency department, non-routine pediatric physician visits. So we're starting with the Interior Health Authority, and we will have all of the same kinds of evaluation strategies that we did for SmartMOM. And again, we have got our messages developed now, and we have been working from the very beginning with our Ministry of Health, and the goal is that they will take it over in the long term. Right now, the operational costs are entirely assumed by the health authorities, so it was grant funded to start with. And the grant is still paying for the innovations and the evaluation, but the day-to-day running of the program is paid for by the health authorities. and that's our Smart Parent team. And then our advisory committee, just to say that we have representation from all of the health authorities, from our industry partner from Perinatal Services BC, which is our provincial organization that is mandated to provide perinatal care, and Child Health BC is the same thing for pediatric care. And then we have pregnancy outreach programs on board, and the Canadian Fetal Alcohol Syndrome Disorder group as well. And then this is our contact information. So I think just before we go to questions and discussion, I'll just make another couple of points. We have applied for a grant to make an app, and we didn't start out with apps, but we have learned that on some of our Indigenous reservations, women there don't have access to either cell phones or internet, which we didn't know when we started. So we are going to try and put SmartMOM on an app where everything is on the phone and you don't need internet connectivity. So that's something we will try and do. And then in the north, we have been asked to create a program that can have the dual purpose of providing information, but also serve as a program for language rejuvenation for our Indigenous languages. So if we get funded for that, we will be having our messages voice recorded by elders in the community, and they will either be using their own language or they will be using English infused with their wording, and they will use their own teaching strategies to get the message across, including storytelling and singing and all the things that they plan to do. So those are a couple of things that are coming, we hope. And the other comment I wanted to make is that what women have asked us for and what we hope to be able to provide over time is a sense of community with their own peer group in their own community. So we need to have some kind of forum whereby women could communicate in an online manner through a listserv, but also post videos and articles and other things that they want to share with their peer group. And that would be monitored by a public health nurse to make sure that the information was accurate and that she might be able to answer questions. So I think I will stop there. Is this a good time to stop, Emily?
Yeah, that's great. Thank you so much, Patty. This has really been very informative and very exciting to know that this is already going on and that it's so well received. So I really appreciate you introducing this to us. We have a few questions that have already been queued up, but if anybody else has any questions that have come up in the meantime, please just write them in the chat box on the bottom and we'll add them to our list. So let's start off now. So the first question is, how do you spread the word about SmartMOM? I think you did mention some of that, but if you could maybe elaborate.
Well, we have a social media presence. So we're on Twitter, we're on Instagram, and we're on Facebook. And we found that the Facebook has been highly successful. Each health authority has committed their own resources to their health promotion team to spread the word about SmartMOM in whichever way works for them. And so in the north, we did webinars with all the nurse leaders, and then those nurse leaders did it again with all the nurses that reported to them. So it was like a network. We also have tear-off sheets in doctor's offices. So it's like a prescription pad, but you just tear off the sheet and give it to the client. So that's also been helpful. And we do have posters up in the community as well. And we also have things like community newsletters and newspapers, and that has worked. All of the health authorities have local newspapers that they send out to tell people what their own health authority is doing. So that has worked as well. And then the other big thing is that health authorities that have a prenatal registry have done a vast amount of promotion about their registry. So if we're piggybacked on the website to enroll in the registry, then that's a very good way for people to find out about it.
Great, thank you. I think Dr. Voris, I see her mic is unmuted, so let's just see if we could catch this internet wave. Are you here, Dr. Vora? Oh, I saw a change. Not sure if there's delay. So I'll just say if Dr. Vora, if you do end up coming through and you're able to hear, just you can interrupt us. We just want to make sure that, I know with India it can be hit and miss with when the internet's working. So just interrupt if you do manage to come through. So the next question then is, Patty, as an expert on violence against pregnant women, can you talk a bit about this huge public health problem? It's quite a big question.
I'm not sure if that question is in relation to SmartMOM or not, but just in general, we know that the violence increases the rate of perinatal mortality by 7 to 8 times, and there's no other condition in pregnancy associated with that high a mortality rate other than extreme preterm birth. And we know that in about 7 U.S. states that have studied this, violence against women is the leading cause of maternal mortality. So I really believe that the way to deal with this is through our culture and societal changes. I don't think that dealing with individual perpetrators or individual caregivers is the answer. And I think that one of the best things that I have seen is the programs that are about witnesses. And so, for example, in BC, our BC Lions football team took this on, and they had all these big men talking about what their role as a witness was. And so, well, not everyone has been a perpetrator or a victim, but we have all been witnesses. So to understand what you can do, I think public health education has to be aimed at letting people know how to talk about it, how to direct people to resources, how to let people know that they're not alone, and to be someone that can be talked with about violence against pregnant women. And so I think that is the way that we change the norm, and that's when this is going to change.
And so when they click on the supplemental section that is for experience of violence, does it then, you have a series of links, does it link them to someone if they wanted to reach out for help?
Yes, it does. They'll get about 4 different messages at different intervals, and those messages will take them to a number of different resources, including crisis lines, how to get to a safe house, but it'll just give them a lot of information as well.
Great, thank you. Another question we got was, what is the response rate among antenatal women to enroll in SmartMOM? What is the dropout rate, if there is any?
Well, it's hard to know what the denominator is because we're not sure exactly how many women there are that are eligible for SmartMOM because we're not trying to recruit women who are having complications. So we think about 40% of women are signing up, and that's women overall, like that's both nulliparous and multiparous women, so the rate amongst nulliparous women would be higher. Our dropout rate is almost 0. We ask women when they drop out why they're dropping out, and the answer is almost uniformly because they've had a miscarriage. There are some women that drop out because of an early preterm birth. In those 5,000 women, we've only had 1 dropout because she didn't like the program. And over 99% of women said they learned something from it and that they would refer a friend to it. So the other question, 50% of the users, if that says maternal age 11 to 18 years, I don't think that's correct. It's about it's more like 70% of women who are under the age of 24.
Oh, yeah, so the question was, it shows that approximately 50% of the users belong to the maternal age 11 to 18 years. Could you elaborate on that? Yeah, I saw that slide. It was a bit shocking. I think it was 47% is what was in the slide. So that might have been an incorrect.
Yeah, that is under 25.
Oh, okay. So it might have been a mistake there.
Sorry about that.
Okay.
But it is reaching younger people who, of course, are more likely to be on their phone and more comfortable with digital media.
And so the next question was, Patty, what are your thoughts, or what thoughts do you have about SmartMOM and Smart Parent being spread to a country like India, which has already some of these kinds of educational texting programs?
Well, I think if you already have it, then you don't need SmartMOM or Smart Parent. But I have found there's very few parenting texting programs. There's more prenatal texting programs. But I think that if you don't have it, then you can think about what aspects of this would be useful. And what I have heard from some countries is that they feel that the family has to be educated about the value of a texting program. So their texting programs have various components, and one of them is to inform the partner and the extended family as to how they need to take care of a pregnant woman. And the other recipient of texts are traditional birth attendants, so that they can be educated as to how they should be providing care. I think that understanding literacy rates is important, because maybe texting isn't the right way. Maybe it needs to be a voice program. Mm-hmm. And then there's issues of translation. But with translation, there's another question, and that is, are women going to be able to read the links? And are you going to get all the information translated that's on the internet? So it has to be tailored and relevant for the audience that you're aiming at, and that would be different in different areas. But the software is very adaptable. So once you have the software set up to deliver messages, changing the messages is very easy and cheap to do. Switching to voice messaging would be more money, but it's quite doable.
Well, and I think this is a perfect time. We're going to try again to get Dr. Vora in. Can you hear us, Dr. Vora? Oh, so close. She was back. She jumped in. But somehow, see, this is always what happens. We were chatting just fine before this started, and then now her voice isn't coming through. Okay, well, then we'll just go to the next question. All right, so do the services of SmartMOM, are they available after the delivery? Well, I believe that's what you were talking about with Smart Parent, right?
Yeah, there will be, when we start out, sort of a seamless transition into Smart Parent. So if you are enrolled in SmartMOM, you'll find out about Smart Parent, and the health authorities want to make it automatically available for SmartMOM users.
And so if someone had not gone through SmartMOM, would they be able to access Smart Parent?
Yes, and we'll do all of the same kind of social media, but it's not going to be as easy, because parents are not necessarily going to public health agencies in that first year of life. They just might be going to their individual care provider. Mm-hmm. So that will be more of a challenge, but we'll have to work that out with the health authorities.
Okay. Can you talk a bit about the differences between perinatal education programs in person versus in text?
Well, the prenatal education programs cost money, and so it can cost about $100 Canadian to take a program. And the programs now are no longer provided by our health authorities. So they may be with private instructors or community colleges. So there isn't a lot of standardization of the content. And so people may find that the education program is not particularly well suited for them as an individual. And what I think we found a lot is that most pregnant women are working. So to work all day, go home, have dinner, and then come back to a class at night is just exhausting for them. And as well, they're not getting the information at the time they need it. They're getting it way ahead of the birth, months and months ahead of the birth. And that's very different than by texting, because then they get the information just when they need it, and they don't have to pay for it, and they don't have to go anywhere to get it.
That makes sense. I've got another one here. Can you explain how depression rates have decreased with the perinatal education programs, such as?
Well, we don't know exactly what women have done, but we do know that they're following our links, and they tell us in the our follow-up survey that they have accessed help that they found through the links. So our program isn't offering them service, but they do find out when they enroll in the program what their score is on the depression scale. And depending on what score they have, it will tell them this is well within the boundaries of normal, or this is borderline, or you should see your physician. And if the scores are concerning, or if they have any if they're saying they feel suicidal, then they get immediate information right at the point of completing the survey. So they don't have to follow a link anywhere to get that. So I think that that has to be the only way that I know of that they can be decreasing their depression scores, because they are accessing that information.
Great, thank you. Well, I am so disappointed that we're having troubles. Well, we're going to keep waiting with that. We have another question that's come in, though. Can you talk a bit about being a professor of public health and your experiences creating this program, which has required some technical and business skills?
Okay, well, like many people in public health, I had a very long career as a clinician. So I worked in the delivery suite for 20 years. I taught prenatal classes. I worked for public health agencies. So I was very aware of what was needed. And then we started by doing focus groups in the North to learn from women what they wanted. So I would say I'm a very applied person to start with. And then I don't have to know everything. I mean, Memotext knows how to create the software, and I let them do that and deal with their own problems. I also have a young and very tech-savvy manager who works with me, and she keeps her finger on the pulse of all the technical issues. And it used to be a weekly meeting, so when we're starting up a program, we meet every week with our technical team, but now it's down to every month. But we're emailing and phoning in between if anything comes up, so that we can look at it immediately. And we've also had all the technical teams and the health authorities talk to our technical team in Ontario, just so that everybody knows what everybody's doing, and they're all speaking the same language. And so I would say that in my role, I made sure the right people are in the right place and that they're all talking to each other.
Now, a question that, and I was thinking of when we were talking about doing this and about having Dr. Vora on as well, offering some insights on India. One of the things that I was curious about is kind of the economic demographics. And so in Canada, most people have cell phones, and I know a big population in India also have cell phones. But what do you feel the kind of the economic demographic is of people who are using your the app, the SmartMOM app?
Well, I think the socioeconomic status is all over the map, okay. And we're told by public health nurses that 99% of their clients have cell phones. And one of the questions that we asked of the women that have joined so far is, do you have your own phone or did you have to borrow one? And only one person borrowed one and one other person shared one, and everybody else had their own phone. So,
and then the idea of in India, what happens often is that there might be one phone in a family, and it's controlled by the husband. And so, what do you think might be? Do you think that there would be some difficulties in that, in kind of getting the information passed through the husband, or a way to kind of cater to that?
I think what you have to do there is make the husband part of the team. So your program has to be relevant and engaging for the partner, and they have to feel that there's benefit to this program. And if they're controlling the phone, then they're controlling the information. And so you have to make that information something that the husband wants to receive and sees value in. So you have to address that head on and aim your messages towards the person who has control of the phone as well as your end user, the pregnant woman.
Great, thank you. Now we have, LAL is raising their hand to ask a question. So what we'll do is if you have a question, just actually write it into the message chat box at the bottom, because we wouldn't be able to get the microphone on for you. So if you guys can hear that, if you have the question, there should be a section at the bottom, a chat. And so if you write that in there, we can answer it for you. Or they might have accidentally just tapped the chat button, which can sometimes happen as well. Another question, do you plan to expand SmartMOM to other countries?
Yes, we would certainly like to work with other countries who want to do this, and it's easy for memo text to do this. So we would certainly be willing to work with other countries to do this.
Oh, that's great. Are there any in progress, or you're still putting out your feelers? Or?
We've been approached by Cyprus, by Pakistan, by Uganda, and by Cameroon.
Oh, great.
And we're just talking about it right now, but it's been a full-time job getting it up and running here. We've also been approached by Saskatchewan and Ontario and Alberta. So we're just letting that evolve and starting to write grants with people, and we'll see what happens. But I think particularly in Canada, but even beyond, if we've done this, like, why would anyone else develop their own set of messages? It's much easier just to adapt the messages and not start from the beginning. And the technology's all been done, so that's easily transferred.
Well, thank you. So we'll wait one more minute just to see if anybody has anything else to ask. And oh, actually, there was one more question that came on. Is are the messages visual?
The messages are not. The links in them are. So some of those links go to websites where there's a lot of pictures. Some of them actually go to videos. We don't have pictographs in the messages because SMS is text. It has to be a text, and then the link goes to a website where it can be anything. In order for the message to be visual, it would have to be different. It would have to be on an app.
Oops. Thank you. Well, that's good. Thank you. I'm trying to think of what we can do as a solution when it comes to Dr. Vor's commentary, because I would have loved to hear that. But I think what we can do is This has been so fantastic and informative, and I really appreciate everything you've been sharing, Dr. Jansen. And perhaps what we can do is we can have Dr. Vora see your this video and actually do a video reply, and then put them together and maybe like answer some of the questions. And then when we put the recording up, because all of our recordings are on our Facebook page, what we can do is we can actually put kind of a reply of some of the, because I know she had some commentary on what has been currently done in India, where they've had some hiccups, where they've had some challenges. And so we could kind of have her commentary on it, her discussion. And then after that, maybe even a little bit of brainstorming that could go on. And we could put that all up on the on our Facebook recording section. So this might be a work in progress over the next week or two, but what we'll do is we will definitely connect with Dr. Vora to hear what her thoughts were on this issue, and some of the things that you've shared, because just because it's been done in India and they have had challenges doesn't mean that it was done the exact same way, and it sounds like you've really had a very thorough look at everything that is needed to be able to create this program. So I think it'll be really interesting to hear her take on what you've shared today. I really appreciate, thank you so much for everything you have shared. It, yeah, it looks like we're going to probably wrap it up here. I think that's all of the questions we have today. So as I mentioned to everyone, and Lorianne, if you want to switch to the last slide, if you go, we have a Facebook page, Maternal Infant Health Canada. On Facebook, it is MIHCAN. And on there, what we're going to do is we're going to have this recorded along with all of our webinars. And so you can go to that section of Facebook and join, and then you'll actually have access to this recording and all of the other ones we've done. And so we've done 3 others this year and several last year as well. So yes, thank you everybody for tuning in. It was an absolute pleasure to hear about this. So thank you so much, buddy.
Thank you for having me.